Okay, good afternoon, everyone, and welcome to this deep dive session. I am Ethan Khantana. I'm a pathologist at Stellenbosch University, and I'm very happy to be chairing the session today. Today's presentation is going to focus mainly on the practical integration of some of the core laboratory diagnostic tests in hematological disease by using a case-based approach. And I think this is a very relevant topic for all of us because modern hematology increasingly depends on combining all of these different testing modalities, such as your full blood count, the morphology in the peripheral blood and bone marrow, immunophenotyping, biochemical testing, and there is more and more a bigger focus on molecular and cytogenetic investigations as well, so that we can arrive at an accurate diagnosis and a risk stratification. So we are fortunate to have Dr. Rubieparasad presenting today. She will take us through the diagnostic workup of a multiple myeloma case in a very practical way, highlighting not only how the different investigations contribute to this hematological diagnosis and a risk stratification, but also the important pitfalls and some limitations of these tests as well. But before we start, as always, just a few important things. Firstly, we would like to thank the Deep Dive management team for putting all of these sessions together. We do appreciate all the effort that you put in behind the scenes and also for giving our registrars the opportunity and the exposure to present on this platform. All the sessions are recorded and can be found on the Blood Assay website, which is quite easy to navigate. You won't get lost there. And you will be muted for the duration of the presentation just to avoid some of the background noise or disturbance. So if you do have questions during the presentation, feel free to ask them in the chat box, and we will do our best to respond to these at the end of the presentation when we will make some time for a Q&A. And then also just to get your very important CPD points, please make sure that you are attending for with your own registered Zoom link and not as part of a group, and that you attend for at least an hour, and also that your HPCSA number is entered correctly when you register for the session. Please make sure of that. You can join the deep dive mailing list via the Blood Assay website, and we would forever be grateful for the feedback that you provide at the end of this presentation so that we can continue to improve the content and the sessions. Then there are also just a few important upcoming events. The 2026 Physicians Conference, which will be held at the Protea Hotel Conference Center in Stellenbosch from the 4th to the 6th of June. SASMO is taking place from 7 to 9 August at the Sandton Convention Center. And then the 18th annual Hematology Oncology Conference will be taking place in October at the Century City Conference Center. And just note that the closing date for abstract submissions is on the 30th of July of this year. So you still have some time for your data analysis. And then just looking forward to next week, Prof. Johnny Mahlangu will be presenting on non-factor therapy in hemophilia. So it is now my pleasure to invite Dr. Rubieparasad to present her talk titled Integrating Laboratory Diagnostic Tests in Hematological Disease, a Case-Based Approach. She is a final year hematopathology registrar at Stellenbosch University, and the research component of her MEd focuses on the clinical pathological features of DLBCL, and she has a particular interest in the diagnostic and prognostic correlations in lymphoid malignancies. But more importantly, I think outside of medicine, she enjoys traveling, hiking, and exploring new cultures and landscapes. So, Dia, I will stop sharing now so that you can go ahead with your presentation. We are looking forward to a very interesting talk.
Hi everyone, welcome to Deep Dive. I will now share my slides. Can you see my presentation?
Yeah, very good. Please go ahead. Thank you, Dia.
Okay. Put my pointer on. Okay, great. Good afternoon, everyone. My topic will be looking at integrating laboratory diagnostic tests in hematological disease using a case-based approach. So I just want to reiterate that the focus of my presentation will be mainly on diagnostic modalities rather than the context of disease. So this slide outlines the structured approach that's going to be used throughout the presentation, which allows us to start first with the clinical question and define the diagnostic problem. We then will select the most appropriate tests and explain what they are and what exactly they mean. We then move over to looking at the principles of each test and what exactly they measure. We'll then move to interpretation of the results. And lastly, we look at the diagnostic pitfalls and limitations because no test should be interpreted in isolation. So our case starts with a 67-year-old male who presented to the outpatient clinic. He reported a 3-month history of fatigue and backache. There was no associated comorbidities, and he did not report any constitutional symptoms, bleeding symptoms, or any recurrent infections. On further inquiry, he did not report any use of medication or a background history of alcohol use, and there was no associated blood transfusion or surgical history that was documented. On examination, the patient was apyrexial with normal vitals. The only significant finding was that he had a conjunctival pallor. There was no associated jaundice, edema, lymphadenopathy, organomegaly, or any masses that were noted, and his cardiovascular and respiratory exam was otherwise unremarkable. So based on the patient's presenting complaint of this backache, a thoracic lumbar X-ray was ordered, and the radiologist reported that there were lytic lesions noted in the T9, T10 region. And if we look at the lateral X-ray, we can see that there's vertebral decompression with an osteopenic appearance noted. So this confirmed the presence of lytic lesions. So based on the patient's age, fatigue, conjunctival pallor, and the presence of lytic lesions, the first question raised was, is there a possible hematological cause for the anemia? Some of the differentials at this stage included anemia of chronic disease, marrow infiltration by malignancy, or could it be a possible primary hematological disorder? And we know that these conditions produce a normocytic normochromic anemia. So at this point, a full blood count and peripheral smear were ordered to further characterize the anemia and assess for the likely cause. So a full blood count is performed on an EDTA anticoagulated whole blood sample using an automated analyzer. The analyzer aspirates a small volume of blood and generates quantitative data on red and white cells as well as platelets using a combination of principles such as electrical impedance, optical light scatter, and spectrophotometric hemoglobin measurement. This was the patient's FBC, and we can see that he had an anemia of 8.6 grams per deciliter with a decreased red cell count and a slightly increased mean cell volume of 99.3 femtoliters. His white cell count and platelet count were otherwise unremarkable. So at this point, it raised the possibility of an evolving macrocytic anemia, and correlation with the peripheral smear was then required. At this point, I want you to have the following differentials in mind as these are the most common causes of macrocytic anemia. Could it be a megaloblastic anemia due to vitamin B12 or folate deficiency? Or could it be due to a non-megaloblastic process, such as myelodysplastic syndrome, hypothyroidism, liver disease, or due to drugs or alcoholism, which the patient did not report any components thereof. So next we move to a peripheral smear, and this diagram demonstrates the different regions of a peripheral blood smear when assessing morphologically. So starting at the head of the film, one can see that the red cells show significant overlap and white cell morphology is distorted. So this makes morphology quite difficult to assess, giving the appearance of a pseudo-rouleau formation. We then move from the head of the film to the body until we reach this area here, as indicated by the green arrow, which is the optimal site for assessment. As we can see, there's minimal overlap of the red cells, and there's clear central pallor noted within each red cell. Also, we can very nicely see the white cells noted here. From here, if we move to the end of the smear, we come to the tail. And this is the thinnest region of the smear where the red cells appear quite distorted as they are quite widely spread out. The areas of central pallor are lost, giving the appearance of a pseudo-spherocytosis. So essentially, the site of examination becomes quite important to interpret the morphology accurately. So this is the peripheral smear of the patient. And what was noted was that he had normocytic, normochromic red cells with prominent rouleau formation as depicted here. There was no round or oval macrocytes to suggest a megaloblastic process. There were no round macrocytes, nor were they target cells to suggest liver disease. There was also no associated features of hemolysis, such as fragments, spherocytes, agglutination, or any nucleated red blood cells. The neutrophils showed normal morphology. There was no hypersegmented or hypolobated neutrophils to suggest a possible myelodysplastic syndrome. There was also no toxic neutrophils to suggest an underlying inflammatory or infective process. No blasts or atypical lymphocytes were seen to suggest a possible acute leukemia or lymphoproliferative process. And overall, there was no leukoerythroblastic reaction to make us think that there could be a possible infiltrative process going on at this point. So an important pitfall is that rouleau formation may artifactually elevate the mean cell volume on automated analyzers, as red cell aggregates may be interpreted as larger particles during impedance-based measurement. And it's important to note at this point that vitamin B12 and folate assays were normal, as well as the LFT and thyroid function test, which were ordered when the diagnosis of macrocytic anemia was made based on the FBC. So moving on to the rheology of how does rouleau formation occur. So normal red blood cells usually repel each other because their membranes have a negative surface charge. So this creates a zeta potential which keeps erythrocytes separated in circulation. In conditions where we have increased plasma proteins, the proteins neutralize or bridge the negative charges between the red blood cells, causing the red cells to lose their repulsion and aggregate. And they usually form this appearance of a stack of coins as seen in this slide here. So if we have to ask ourselves, what are some of the causes of rouleau formation? Commonly, we have monoclonal gammopathy, which is caused by excess monoclonal immunoglobulins, or it could be caused by inflammatory or infective states like acute and chronic infection or connective tissue disorders, as there's an increased production of acute phase reactants. Lastly, chronic liver disease can also attribute towards rouleau formation, as there is a plasma protein composition imbalance. And based on the patient's clinical presentation, FBC, and morphological findings, an inflammatory or infective process was unlikely, and based on the patient's peripheral film, there was no target cells and the LFT was normal. So at this point, we're strongly suspecting that there could be a monoclonal gammopathy. So the next question we ask ourselves is there a monoclonal protein? And for that, we have 3 tests that can assist us in answering this question. And that includes serum protein electrophoresis, immunofixation electrophoresis, and serum-free light chains. In order for us to better understand these tests, it's important to understand a little bit about physiology. So in healthy individuals, polyclonal plasma cells produce a wide variety of immunoglobulins with different heavy and light chains. And because these immunoglobulins have slightly different electrophoretic mobilities, they distribute broadly across the gamma region, producing a broad-based polyclonal pattern. In contrast, a monoclonal process arises from clonal expansion of a single abnormal plasma cell. Since all the immunoglobulins or free light chains produced are identical, they migrate together, forming a monoclonal peak in the gamma region. So essentially, the principle of serum protein electrophoresis is the separation of proteins based on electrophoretic potential in a liquid at an alkaline pH. What this does is it causes the proteins to become negatively charged, and they then move from the cathode to the anode. This is what you see or what you expect, as the S-PEP will separate the proteins into 5 bands, with most of the proteins being distributed here in the albumin band here, followed by alpha-1, alpha-2, beta, and gamma, in which there's a much smaller fraction of the total serum component. So this is what we expect to find under normal circumstances. So this is the S-PEP result for the patient. And we can see that on the left-hand side here, we have a control with the 5 different bands, with a prominent band being noted in albumin. That's what we expect, followed by faint bands thereafter. If we have to compare the control to our patient, which is depicted by the lane with a red star, you can see that there's a prominent band in the gamma region. So this information is then converted into a densitometric curve, which we saw on the previous slide, and it then quantifies the findings. So you all are familiar with this printout of the serum protein electrophoresis interpretation. And if we can compare what we are seeing here to the interpretation, we can see that there's a monoclonal peak in the gamma region. As we can see here, this is the only globulin that's elevated, of which the monoclonal protein makes up 58 grams per liter. So this is a quantitative test, and it also tells us that a monoclonal protein is present. So this is all it can tell us at this point, in addition to giving us the quantification. Some of the strengths of serum protein electrophoresis is that it's usually preferred over urine protein electrophoresis from a practical point of view, as a single sample is required for serum protein electrophoresis compared to urine, which requires large volumes of urine collected over a 24-hour period, which is quite inconvenient for physicians as well as patients who have poor compliance with this. Some of the pitfalls are that serum protein electrophoresis is sensitive to monoclonal protein above 5 grams per liter. So non-secretory or oligosecretory disease may be missed. And also, there's a reduced sensitivity for agamma-globulinemia, which means that if a physician is clinically suspecting that a patient has agamma-globulinemia and the S-PEP comes back normal, they should actually order immunofixation because it's not going to reflexively be done, as in a case in which a monoclonal band is detected. At this point, we can also mention that monoclonal protein can falsely increase hemoglobin as it increases the turbidity in the spectrophotometric assessment of hemoglobin. And if a patient has an anemia that's not in keeping with the clinical presentation, then this is also something to think about. So next we move on to immunofixation. And on the left, we can see the patient's serum protein electrophoresis result. And what we do next is we take antibodies to the heavy and light chains, and whichever monoclonal protein is present, it forms an antigen-antibody complex which precipitates in the gel. So in our patient, we can see that there's a prominent band in the IgG lane as well as the kappa lane. So this patient has an IgG kappa monoclonal gammopathy. And if we look at how it's interpreted, it's a qualitative assessment which describes the isotype and the light chain. It also reports that immunopoiesis is present based on the absence of other heavy chains and the absence of the light chain. So the value of 58 grams per liter does not come from the immunofixation result, but rather the serum protein electrophoresis result. So immunofixation helps us to answer the questions, what isotype is present, and in our case it's IgG, and which light chain is present, and the answer to that is kappa. So urine protein electrophoresis follows exactly the same principles to assess for Bence-Jones monoclonal protein. Some of the strengths of SPEP is that it has a higher sensitivity than SPEP, as it can detect lower concentrations of monoclonal protein, and it has a higher sensitivity for detecting agammaglobulinemia, as we previously alluded to. Some of the pitfalls is that immunofixation is a qualitative test, so it cannot quantify light chains, and it has a lower sensitivity than the serum-free light chain assay. Lastly, from our biochemistry tests, we speak about serum-free light chains. And this is an immunoturbidimetric assay which uses antibodies that specifically detect free kappa and lambda light chains by detecting epitopes that are usually hidden on intact immunoglobulins. So it essentially measures circulating free light chains. And this test is quite sensitive for light chain disease, and it can be used to assess light chain restriction. So our patient had a free kappa light chain result of 44.2 milligrams per liter, which was increased, and a free lambda light chain result of 8.1 milligrams per liter, which was normal. We can see that the ratio was 5.46, which was abnormal, as we expect the ratio to be between 0.26 and 1.65. So serum-free light chains helps us to answer, is there light chain restriction? And the answer in this case is yes. So some of the strengths of this assay is that it's more sensitive than serum protein electrophoresis and immunofixation, as it can detect light chain concentrations less than 1 milligrams per liter. It's reproducible and preferred over urine protein electrophoresis and immunofixation for reasons mentioned earlier. But in addition, urine protein electrophoresis is a semi-quantitative test and more labor-intensive, whereas serum-free light chains is fully automated. Some of the pitfalls here is that it can produce a positive result in the setting of renal impairment and inflammatory conditions, as both light chains can be increased proportionately. I also just want to mention at this point, if a patient has renal impairment with a light chain value of 1,500 milligrams per liter or more, it can be inferred that there's a light chain cast nephropathy, and it's not necessary that a renal biopsy should be performed. So now that we know the patient has a monoclonal gammopathy, we can work up the diagnosis And these are some of the differentials we currently have. Could it be a non-IgM monoclonal gammopathy of undetermined significance? Could it be a smoldering multiple myeloma or multiple myeloma? So based on our findings, the criteria requires one to have a serum monoclonal protein of less than 30 grams per liter for MGUS. And we had a finding of 58 grams per liter, which is way above the threshold. So we can automatically exclude that as a cause. In addition, we did have myeloma defining events. However, at this point, I would like to mention that one should be cautious about defining the anemia as a myeloma defining event at this point, as we're not really sure if it's secondary to the infiltration, if it's secondary to bone marrow infiltration. So next, we would have to work up for all the myeloma defining events and then proceed with a bone marrow to assess for plasma cells, which would give us a clue to what the diagnosis could be. So the patient had a serum creatinine of 48 micromoles per liter, which was normal, and an EGFR of more than 60, which was also normal. It's important to note here that just having an elevated creatinine is not a myeloma defining event, and one has to have a creatinine of more than 177 micromoles per liter or a EGFR of less than 40 moles per minute. The patient's calcium was 2.23 millimoles per liter, which was normal. Just to reiterate again, hypercalcemia alone is not a myeloma defining event. It has to meet the criteria of having a value of more than 2.75 millimoles per liter or be higher than 0.25 millimoles per liter than the upper limit of normal. So now that we know the patient just has two myeloma defining events, we next need to find out if there's a plasmacytosis. And for this, we need to investigate with a bone marrow aspirate and trephine. So a bone marrow aspirate is obtained using negative pressure to collect marrow particles and cells for cytological assessment, while a trephine biopsy entails obtaining a core of bone to evaluate bone marrow architecture, cellularity, infiltration, as well as fibrosis. So these procedures are performed for various indications, some of which include hematological malignancies such as acute leukemias, lymphomas, myeloproliferative neoplasms, plasma cell disorders, MDS, and decreased marrow production states such as aplastic anemia, just to name a few. So this slide demonstrates what a normal aspirate looks like. So starting with the image on the left, this is a low power view of a marrow aspirate particle, where the overall cellularity can be assessed in relation to the patient's age. Moving on to a higher magnification, looking at the trails of the sample, we always assess the megakaryocytes, we assess erythropoiesis and granulopoiesis. So here we can see a mature lobulated megakaryocyte with abundant cytoplasm. Here we can see erythroid precursors at different stages of maturation from very early to very late. We can also see granulopoiesis from a blast, promyelocyte, myelocyte, metamyelocyte band, and neutrophil. It's normal to see blasts in the bone marrow, but as long as they're not increased. In addition, there's also small mature lymphocytes that can be seen as well. So coming back to our patient, this was the patient's aspirate, and we can see that he has a markedly hypercellular particle as well as a markedly hypercellular trail there. And we don't expect a 67-year-old to have such a high cellularity. The patient had fairly preserved megakaryopoiesis, which is not shown here, and there was decreased erythropoiesis and granulopoiesis. As you can see here, there's just one promyelocyte and one erythroid precursor. So we can see it's markedly decreased. And the majority of the cells that were seen were these plasma cells. And as you can see, they range from normal small plasma cells to these large atypical plasma cells that had abundant basophilic cytoplasm with an eccentric nucleus that's quite clumped and shows this clockwise appearance here. There's also binucleated forms and vacuolations that were seen. I just mentioned here in bold that there was a decreased erythropoiesis, and at this point we can confirm that the anemia was due to bone marrow infiltration. So these pictures depict some atypical plasma cell morphology, which our patient did not have, but just for interest's sake, we can have Ducher bodies, which is essentially invagination of the cytoplasm over the nucleus, as depicted here. We can have flame cells, which is the eosinophilic appearance that can be seen at the periphery of the plasma cell. We can have Mott cells, which essentially are plasma cells that have become overloaded with retained immunoglobulin. And because this protein cannot be secreted efficiently, it accumulates inside the rough endoplasmic reticulum, creating these multiple round inclusions known as Russell bodies. And over here, you can see Russell bodies in isolation. So what are some of the pitfalls of the bone marrow aspirate in this context? Sampling variability. So the first one is patchy marrow infiltration, which means that infiltration can be uneven or focal. So a single biopsy site may miss the areas with increased infiltration, causing falsely low plasma cell counts. Peripheral blood contamination can dilute the bone marrow sample, leading to an underestimation of plasma cells. So to counteract this, only 1 ml of blood should be aspirated as it contains pure bone marrow elements. And inter-observer variability. So manual morphological estimation of plasma cells depends heavily on observer expertise, but also a few percentages off can also affect the diagnosis. And aspirates tend to yield lower percentages compared to trephine biopsies as a result of poor fallout of plasma cells from particles. Moving on to the trephine, this is what a normal trephine looks like, and this is what the architecture is supposed to look like. So starting at the top, we have the trabecular bone, followed by the endosteal zone, which is rich in granulocytic precursors. We then have the intermediate zone, where we see erythroid precursors, which are these dark cells here, and mature granulocytes, which are depicted by eosinophils and neutrophils. Going more centrally, that's where we usually see our megakaryocytes, which are depicted here. These are the much larger cells. And in a healthy adult marrow, we expect age-appropriate cellularity. This is the trephine of our patient, and as you can see, it was markedly hypercellular for his age, and there was complete effacement of the architecture in certain areas, as we could see that there's no plasmas, no flat spaces in each in every area. So here we can see the disturbance of the architecture, as most of the cells here are medium to large plasma cells with abundant cytoplasm, and we can see this clock face chromatin here. We see virtually no megakaryocytes, granulopoiesis or erythropoiesis in this particular section. And it was noted that the sinusoids were increased, but there were no thickened blood vessels. And we usually assess for thickened blood vessels as we want to exclude amyloidosis. So this patient did not have any thickened blood vessels, but this is an example of what we would be looking for. So in this H&E trephine, we can see that there's these pink amorphous thickened blood vessels as noted here. And we would then stain for them using a Congo stain. And if we look at a Congo stain under light microscopy, we can see the salmon pink appearance. But if we use polarized light, we see this apple green birefringence. So essentially we use the same stain, but use two different modalities to identify. Next, we move on to immunohistochemistry, which is essentially the detection of specific antigens on the trephine using chromogenic antibodies. So in this case, we use CD138 as it's quite sensitive and specific for plasma cells. And this patient had a total plasma cells were estimated at 70%. So these are some of the advantages and disadvantages of using immunohistochemistry. So the advantages include that it's readily available and it's more sensitive for plasma cell estimation compared to using the bone marrow aspirate. However, there are some cases where the aspirate can have more plasma cells than the bone marrow trephine, and in that case, the higher percentage will be used. It can also be used to determine clonality by kappa and lambda antigens. We did not use this in our case as we confirmed clonality with flow cytometry, as will be explained in a few minutes. And some of the disadvantages is that it requires tissue processing and specialized reagents, which can be quite time consuming with an increased turnaround time and also quite expensive. And another disadvantage is that the interpretation on the tumor burden is very subjective. In our context, some of the pitfalls of the trephine biopsy, as we previously mentioned, the patchy nature of disease in monoclonal gammopathies and inadequate quality. So in terms of inadequate quality in this case, plasma cells are quite fragile and friable, and hemorrhage can distort the morphology, which makes interpretation quite difficult. And bone marrow biopsy quality is usually operator dependent, and it generally improves with procedural experience and seniority. So now that we know the patient has a plasmacytosis, we need to consider some of the clonal causes and reactive causes. So reactive causes include things like infection, such as HIV and other opportunistic infections. It could be chronic inflammatory disease. Some of the clonal causes include plasma cell neoplasms like multiple myeloma, monoclonal gammopathy of undetermined significance, amyloidosis, and other hematological malignancies like angioimmunoblastic T-cell lymphoma and multicentric Castleman's disease. So now that we have a plasmacytosis, we need to ask ourselves, is the plasmacytosis clonal? And for that, we need to run flow cytometry on a bone marrow aspirate, or we can use immunohistochemistry on the bone marrow trephine. So we already touched on immunohistochemistry. Now we'll focus on flow cytometry. So this is the workflow of flow cytometry, but for practical purposes, flow cytometry uses fluorescently labeled antibodies, which are directed against specific antigen epitopes on cells. So these fluorochromes are excited by lasers in the instrument, which emit light, which is then detected by photodiodes, allowing assessment of the presence or absence of specific antigens. So this process involves multiple washing and centrifuging steps, making it very labor-intensive and time-consuming. However, flow cytometry is more sensitive than immunohistochemistry for detecting small abnormal plasma cell populations and distinguishing between neoplastic from normal plasma cells. At our center, flow cytometry is preferred because it's more reproducible, has a faster turnaround time compared to immunohistochemistry, and less affected by technical challenges such as subjective tumor burden estimation and variable staining quality seen with immunohistochemistry. So this is the flow cytometry for our patient. And for our particular question, assessing plasma cells, we used a plasma cell sorting tube, which consists of 8 antibodies, which are depicted in the first column here. And we usually have raw data that we have to self-analyze. So what we first do is we have to first gate CD138 against CD38, as we know, that's the particular antigen that is positive for plasma cells. And based on this, we can see this purple population is positive for both CD138 and 38. So this is our plasma cell population. Next, we need to gate other populations such as lymphocytes, granulocytes, monocytes. And once we gate them, they look like this. This is a side scatter CD45, and side scatter simply means the complexity. So the most complex cells will be seen up here, and the least will be seen down there. So that's your granulocytes, monocytes, lymphocytes, and your plasma cells can be seen there. So I think it's important to mention B cells as an important population, as we can see here that it's demonstrated by being CD19 positive. And we know that B cells express kappa and lambda as well. So when we want to confirm clonality, we look at the cytoplasmic lambda and kappa gate, and we draw a diagonal line from the center. And we can see that the B cells, as depicted by this blue population, they on either side of the line, proving that they're polyclonal. And we can see that the plasma cells all lie to the right side of the line, proving that they're clonal. So we do have a clonal population of plasma cells, but now we also want to assess if they are neoplastic, if they have neoplastic antigens. And the second column here depicts what the normal antigens, or what normal plasma cells would express rather, and what neoplastic plasma cells express. But this here is our patient's results. So our CD45 was negative, our CD19 was negative as depicted here. If our blue population here is positive, our plasma cells are negative, and CD56, which is here, is positive. So we can confirm that we have a monoclonal population of neoplastic plasma cells. Some of the pitfalls of flow cytometry is that expensive equipment is required, and hemodilution and the fragility of cells can reduce the percentage of plasma cells. It can also occur with processing and the washing steps as well. So now that we've excluded MGUS, we look at the other causes, and the factors listed here in red are the factors against these particular monoclonal gammopathies, which leaves us with the diagnosis of multiple myeloma based on the factors listed here in this green box, which include anemia, lytic lesions, and clonal bone marrow plasma cells of more than 60%. So we now identified our diagnosis as multiple myeloma. So with any hematological malignancy, our next step would be to risk stratify the patient. So in the context of multiple myeloma, the second revision of the international staging system is the latest version requirement, and they take into account the ISS stage, which includes albumin and beta-2 microglobulin, the LDH, and FISH for high-risk cytogenetics. So cytogenetics is a term that encompasses both karyotype and fluorescence in situ hybridization. The requirement for cytogenetics is these heparin tubes in which the bone marrow aspirate should be collected. Bone marrow aspirate needs to be cultured and arrested at mitosis to isolate actively dividing cells. However, a pitfall in multiple myeloma is that plasma cells are quite slow growing, and they make this process technically difficult. This is why fluorescence in situ hybridization is preferred, and the basic principle here is that patient cells are fixed onto a slide. At this stage, we can see that DNA is double-stranded and intact. We then add in fluorescently labeled probes, which are specific for specific sites on the DNA. We will then heat the sample to allow denaturation to take place. Basically, this means that the DNA separates into single strands and the same applies to the probes. We then lower the temperature and the probes will bind to their specific site of interest. A counter stain is used, and then the signals are then viewed under fluorescence microscopy. One of the pitfalls here is that hemodilution of the bone marrow can result in a false negative. That's why it's usually advised that the first pull in a bone marrow aspirate should be used for fish, in addition to flow cytometry. So this diagram illustrates we have two different chromosomes. We have probes that are used. So here we have a green probe that it attaches to the IGH region on chromosome 14, and we have a red probe that binds to the FGFR3 region on chromosome 4. And we know that we have two chromosomes, one from our mom and one from our dad. So in an interphase fish, which is depicted here as a circle here, you would have two red signals and two green signals in a patient that does not have a mutation. And this here shows you the same thing, but this is in metaphase where we can clearly see the chromosomes, and we have two red signals and two green signals. So this is what you expect to see in a normal fish assessment. So our patient had a positive result for translocation 414 for the FGFR3 IGHG fusion gene. And as we can see, we have one normal red and one normal green signal and two fusion signals which are yellow. So based on this, we can interpret the test as being positive. I also would just like to mention that the positivity of the fish result does not matter. There's no special implication in this. So coming back to our risk stratification, this just summarizes the different factors that are needed. It's based on the ISS stage, high risk cytogenetics, as well as LDH. And each of these components are given a score. The score is then calculated, and one would then be stratified accordingly from low to high risk. And our patient had an ISS-3 score with elevated LDH and a high-risk cytogenetic. So he was classified as high risk based on having 3.5 points. So this is just to summarize the process of how we came to this diagnosis. So based on the clinical history and examination of the fatigue, conjunctival pallor, and the lytic lesions, we had to ask ourselves if there's a cause, if there's actually a hematological cause for the anemia. And for that, we did the FBC, which showed us a macrocytosis. But we confirmed that it was not a true macrocytosis based on the peripheral smear. On the peripheral smear, we found that it was the rouleau that created this false macrocytosis. Based on the rouleau, we had to ask ourselves, is there a monoclonal peak? For this, we used biochemistry tests, which told us that there was an IgG kappa monoclonal protein with light chain restriction. We then had to confirm that there was a plasmacytosis. For this, we did a bone marrow biopsy, which did confirm this. Now that we had a plasmacytosis, we had to ask ourselves, are these plasma cells clonal? And we proved that there was a clonal immunophenotype using flow cytometry. Once we had all of that, we were able to derive at a diagnosis and risk stratify the patient with high-risk cytogenetics using FISH. So some of the take-home points of this talk is that no single lab test should be interpreted in isolation. Accurate hematological diagnosis requires integration of the clinical findings with morphology, immunophenotyping, biochemical tests, and molecular investigation. Each lab test provides complementary information and has important strengths and limitations. And a systematic and integrated diagnostic approach is essential to ensure accurate diagnosis, classification, and risk stratification in modern hematology. Most of my references were listed on the slide. These are just the ones that were not. And thank you for your attention.
Thank you very much, Dia, for that um, excellent and very practical presentation. Um, we do have some time now for questions and maybe a bit of discussion if anyone is interested. If you do have any questions or comments, please feel free to. I think you will have the opportunity now to unmute yourself and ask the question directly to our speaker, or just type it in the comment section, and I will have the honor of reading your question to the audience. There is one comment from Moses. He says, in this case, would I be crucified for not doing flow cytometry? This is a very good question, Moses.
Thanks, Moses, for your question. It's quite an interesting question. I think there's two sides to this question. Firstly, I think the WHO5 does require clonal plasma cells. So I think if we have to follow literature, then definitely. However, looking at it from a cost point of view, um, especially with insurance companies covering certain tests, I think I wouldn't say okay, but I think it would be reasonable to maybe take that into consideration by preserving funds more for management rather than doing flow cytometry. Well, especially in this case where looking at this case from a clinical point of view, where this patient has he has lytic lesions, he has anemia, he has myeloma defining events, he has a monoclonal protein as well. Usually in an inflammatory or infective process, you don't expect to see a monoclonal protein, but rather a polyclonal increase in immunoglobulins. Serum free light chains would show us an inflammatory picture with both light chains being increased. And personally, I've never seen a plasmacytosis of 70% in a reactive case. So I think clinically, I would say it's reasonable. However, we still need to err on the side of caution. Thanks for the question.
Yeah, I completely agree with you, Dia. I think because the diagnostic criteria require clonality, it is now so-called essential diagnostic criterion rather than desirable. So if you do decide to not prove the clonality, because there is this criticism that sometimes we perform tests unnecessarily when there's ample evidence of clonality based on combination of what you find in the serum protein and the marked plasmacytosis in the marrow. So if you do decide to not prove clonality, I think you should do that at your own risk, but I am quite happy with your answer. Moses, do you have anything else to add?
No, no, not at all, Ethan. Just to say that if I have such a case in a setting that I'm working in Harare, I will not do flow cytometry because I think the evidence is enough for me to treat.
Yeah, no, I completely understand. I completely understand that situation. Are there any other questions? There is nothing happening in the chat. Dia, I think I have one question, and I don't want to put you on the spot here, but just for because your case showed us an MCV value of 99.3, which is just very slightly above the upper limit of the normal reference interval. I just want to maybe put the question to you. Do you think that we sometimes overinterpret results that fall marginally outside the lab reference range?
Thanks, Ethan, for the question. I definitely think that it is a common practice. We basically look at the reference ranges and then automatically just assume that it's either increased or decreased and then investigate accordingly. But I mean, our case did show us that we can't use tests in isolation, we have to, correlate them with other tests to help us. So I don't know if I'm answering your question, but I think we do actually tend to over-investigate. Yeah.
Yeah, no, I agree with you. I think you meant over-interpret the result,
Yes.
but you are right in saying that, and that is also the theme that came across in your presentation, is that we have to interpret all of these results within a specific clinical context. And that is why it's important for us to have that information, but also in the context of the other laboratory investigations. We are well aware of all the complexes and nuances of reference ranges and intervals, and that is definitely a separate or a topic for a separate session. But I think it's important to integrate it, integrate all your tests appropriately. Dalian has a question or a comment. She says, "Thank you for this comprehensive talk. We have emailed the authors of the International Myeloma Working Group paper on the diagnostic criteria to ask the question about the requirement to prove clonality, and the corresponding author agreed with inferring clonality from the SPEP if cost constraints are an issue. Thanks again for the session." Yeah, no, I completely agree with that sentiment that we could probably infer clonality, but I think the important or the focus word there is that we are still inferring the clonality. So could definitely be done, especially if there are cost constraints. Thank you, Dalian. So if there are no further comments or questions, we will bring this session to a close. I would just like to thank you again, Dia, for really an excellent presentation and this small discussion that we had afterwards. I think the session highlighted a very important principle in hematology, that there isn't a single test that makes the diagnosis in isolation, but the test that we request answers very specific clinical questions that will eventually lead us to the diagnosis. So I think this was a very good presentation, and the way in which you presented the case-based format made the diagnostic reasoning especially clear and practical for day-to-day laboratory and clinical work. So once again, thank you for that insightful talk. And then I also just want to thank everyone for your participation. Thanks for joining the session. We hope that you enjoyed it. And please don't forget to provide your anonymous feedback at the end, so that we can continuously improve these sessions. And then enjoy the rest of your Monday evening. Cheers, everyone.
Thanks, everyone.